Think of the thyroid gland as the body's metabolic engine. It dictates the speed of every system, from your heart rate to your cellular heat production. When that engine redlines, the body burns out. When it stalls, the body shuts down. In a hypermetabolic state, like hyperthyroidism, the engine runs in overdrive. Patients present with an enlarged thyroid gland, or goiter, and exophthalmos, the visible bulging of the eyes caused by increased tissue mass behind them. Conversely, a hypothyroid patient is hypometabolic. Their systems are sluggish, they experience profound fatigue, struggle to stay warm in a normal room, and have a noticeably slow heart rate. Charting these chronic, baseline symptoms is standard practice. Your priority as a nurse, however, is recognizing the exact moment a patient loses compensation and tips from chronic dysfunction into a lethal emergency. These life-threatening crises require a trigger. A patient with hyperthyroidism might be pushed into a thyroid storm by an infection, major trauma, or severe emotional stress. On the flip side, a hypothyroid patient can slip into a Myxedema coma from acute illness, or simply receiving a normal dose of sedatives or opioids. When thyroid storm hits, the metabolic engine loses its governor entirely. Look at the vital signs. The heart rate rockets to 160 beats per minute or higher, often throwing the patient into atrial fibrillation. Their temperature can quickly climb above 104 degrees Fahrenheit. The sheer mechanical strain of the tachycardia is the primary threat. The myocardium cannot sustain this massive, continuous output, which rapidly leads to fatal arrhythmias and total cardiovascular collapse. To halt this, you must block the sympathetic spike and shut down hormone production. Your immediate interventions are administering a beta blocker, like propranolol, to protect the heart, followed quickly by antithyroid medications, like methimazole or PTU, to stop the thyroid from making more hormones. You must also cool the patient aggressively with ice packs or cooling blankets. But you must never use aspirin to reduce a thyroid fever. Salicylates unbind thyroxine from proteins in the blood, dumping more active hormone into the system and thereby accelerating the storm. Surviving a thyroid storm relies entirely on how quickly you act to shield the cardiovascular system from complete hypermetabolic exhaustion. Now consider the opposite extreme, Myxedema coma. Here, the vitals crash. The monitor shows profound bradycardia, dropping near 40 beats per minute. Core body temperature falls dangerously low, down to 94 degrees. Arterial blood gases will quickly reveal severe hypoxia and acidosis. The critical vulnerability in myxedema coma is the lungs. Extreme hypometabolism causes severe respiratory metabolism. The patient physically loses the strength to breathe, leading to carbon dioxide retention and complete respiratory failure. Because the mechanism of death is respiratory, your absolute first priority is maintaining airway patency and providing ventilatory support. Once the airway is secure, you treat the root cause by administering rapid intravenous thyroid hormone replacement, typically levothyroxine, to restart the metabolic engine. You also need to address the hypothermia, but do so cautiously. Use warm blankets, not electric heating pads. Active, rapid external warming forces peripheral blood vessels to suddenly dilate, which can tank the patient's blood pressure and trigger circulatory shock. Pause the video and look at these two patients. Patient A is 24 hours post-op, confused, with a temperature of 103 and a heart rate of 150. Patient B was admitted with pneumonia, given a standard dose of morphine, and is now lethargic with a respiratory rate of 8 and a heart rate of 48. What are they experiencing, and what do you do? Patient A's surgical trauma triggered a thyroid storm. They need an EKG and a beta blocker immediately to protect their heart. Patient B's infection and the opioid dose pushed them into a myxedema coma. You need to grab an intubation tray because their respiratory system is failing. Let's try one more prioritization scenario. You receive shift report on two patients. Option A is a patient with a history of hyperthyroidism showing a resting heart rate of 110 and a fine hand tremor. Option B is a patient with hypothyroidism, showing a respiratory rate of 10 and a declining mental status. Who requires your immediate evaluation? You must assess the hypothyroid patient first. While patient A's tachycardia and tremors are concerning, they represent chronic baseline hyperthyroid symptoms. Patient B's low respiratory rate and altered mental status are acute indicators of impending myxedema coma. They are actively dying of respiratory failure. This chart is your final framework for endocrine emergencies. We organize by condition, the key vital sign shifts, the physiological mechanism of death, and the core interventions. Mapping it this way removes the guesswork from your clinical practice. Always trace a patient's symptoms directly back to the underlying mechanism of death. Whether it's heart failure from a thyroid storm or respiratory failure from a coma, understanding how the disease kills dictates exactly what you must